Imagine a young person, let's call her Sarah, enjoying a brisk run on a beautiful morning. The path is uneven. In a split second, her foot lands awkwardly, and a sharp, searing sensation shoots up from her ankle. She stumbles to a stop, her ankle throbbing with a newfound pulse of its own. Within minutes, the area begins to change. It grows warm to the touch. A blush of red spreads across the skin, and a noticeable puffiness starts to obscure the normal shape of her joint. Moving it sends waves of discomfort, making it nearly impossible to put any weight on it. What Sarah is experiencing is a classic, powerful, and entirely normal biological process. Her body has sounded an alarm, and this immediate localized response is known as acute inflammation. This essay will explain this fundamental process in simple terms, showing how the body works to fix an injury just like Sarah's. Inflammation is not the enemy. Rather, it is the body's first line of defense against harm. It is a rapid and protective reaction that occurs in living, vascularized tissue following an injury or an infection. Think of it as the emergency services of the body. When damage occurs, a complex series of events is initiated with two primary goals in mind. The first goal is to eliminate the initial cause of the cell injury, such as bacteria, viruses, toxins, or the damaged cells and tissues themselves. The second goal is to begin the process of clearing out the debris and initiating the repair of the affected tissue. Without this immediate and coordinated response, wounds would never heal, and minor infections could quickly become life-threatening. It is the body's way of containing the problem and setting the stage for recovery. Acute inflammation, specifically, is the short-term component of this process. It develops quickly, usually within minutes to hours of the initial insult, and it is designed to be self-limiting, typically lasting for only a few days. Its job is to deliver defensive elements, plasma proteins and white blood cells, primarily neutrophils, from the bloodstream to the exact site where they are needed. It is a dynamic and robust mobilization, a biological call to arms. Understanding this helps us see inflammation not as a disease itself, but as a vital part of health and healing. The physical trauma of Sarah's twisted ankle damaged tiny blood vessels and connective tissue cells. These injured cells immediately release chemical signals into their surroundings, like a distress flare fired into the sky. These signals are the triggers that set the entire inflammatory cascade into motion. They alert the nearby blood vessels and circulating immune cells that a problem has occurred and help is needed. This initial signaling is the critical first step that transforms a quiet, stable tissue environment into an active zone of defense and repair. The body does not wait. It acts with precision and speed to protect itself from further damage and to begin the crucial work of healing. The experience of acute inflammation has been recognized for centuries. A Roman encyclopedist named Celsus, writing in the 1st century AD, first described 4 of its key features. A 5th was added later. These are known as the 5 cardinal signs of inflammation, and they provide a clear, observable guide to what is happening at the tissue level. The signs are redness, rubor heat, calor swelling tumor. Dolor loss of function, functio, lyesa. Each sign is a direct consequence of specific physiological events in the injured tissue. Sarah's ankle, red, warm, swollen, painful, cannot use it properly. These signs tell the story of the body's vascular and cellular response. Redness and heat are the first signs to appear, and they share a common cause: increased blood flow to the injured area. In response to chemical signals released by damaged cells, the arterioles nearby temporarily relax and widen. This process is called vasodilation. Imagine a 2-lane road suddenly expanding into a 6-lane highway. The widening allows much more blood into the capillary beds of the affected tissue. Blood is warm and red, so this influx heats the surface and creates redness. Increased blood flow delivers cells and proteins to fight injury. Swelling or edema is caused by fluid accumulating between tissue cells. Chemical mediators also make capillaries more leaky. This is increased capillary permeability. Endothelial cells pull apart slightly, creating gaps. Fluid, proteins, and cells pass from blood into tissue. That fluid, exudate, causes visible swelling. The entire inflammatory response is orchestrated by a symphony of chemical mediators. These are substances produced by the body that initiate and regulate the process. One of the most important and fastest acting of these mediators is histamine. Histamine is stored in large quantities within specialized immune cells called mast cells, which are strategically located in connective tissues throughout the body, including near blood vessels, skin, mucous membranes. When an injury occurs, whether from physical trauma or an allergen or a pathogen, these mast cells are triggered to rapidly release their stores of histamine into the surrounding area. This process, called degranulation, is like pulling the pin on a grenade. It has an immediate and powerful effect on the local environment. The primary role of histamine in the early stages of acute inflammation is to cause vasodilation, increased capillary permeability. It acts directly on the smooth muscle of the small arterioles, causing them to relax and widen, which accounts for the rapid onset of redness and heat. At the same time, histamine acts on the endothelial cells that line the capillaries, causing them to contract and pull apart. This creates the gaps that allow protein-rich fluid to leak from the blood into the tissues, leading to swelling. Histamine is the principal mediator of this immediate, transient phase of the vascular response. Its effects are powerful but short-lived, setting the stage for other, more sustained mediators to take over. As the process unfolds, other chemical mediators are produced or activated, creating what is essentially a chemical scent trail for immune cells. This process of cells moving along a chemical gradient from an area of low concentration to an area of high concentration is called chemotaxis. It is the body's GPS system for its cellular defenders. The chemical signals known as chemoattractants can include components from bacteria proteins from the complement system cytokines released by immune cells already at the scene. This chemotactic trail ensures that the right cells are recruited from the bloodstream and guided precisely to the site where they are needed most. The purpose of this intricate chemical signaling is to bridge the gap between the initial vascular events, the vasodilation and increased permeability, and the subsequent cellular events. It is not enough to simply deliver more blood to the area. The body must ensure that the white blood cells carried within that blood can get out of the vessels and find their way to the specific location of the damage or infection. Chemotaxis is the crucial mechanism that makes this targeted migration possible. It is a highly efficient system that transforms the bloodstream from a simple transport highway into a guided delivery service, ensuring that the cellular army arrives at the correct battlefield to engage the enemy and begin the cleanup operation. The cellular phase of inflammation involves the recruitment of white blood cells, or leukocytes, from the blood to the site of injury. The first and most numerous soldiers to answer the call are the neutrophils. They are the first responders of the immune system. Following the chemotactic signals, neutrophils in the bloodstream begin to stick to the inner walls of the capillaries near the injury site. They then squeeze through the gaps between the endothelial cells, a process called diapedesis, and migrate into the tissue. They typically begin to arrive within 60 to 90 minutes and are the predominant cell type at the site of inflammation for the first 24 hours. Their primary job is to act as voracious eaters, or phagocytes. Once in the tissue, neutrophils get to work immediately. They are experts at phagocytosis, which means cell eating. They engulf and destroy invading microorganisms, such as bacteria, damaged host cells, other debris. Neutrophils are essentially suicide bombers. They are short-lived, typically surviving for only a few hours to a day after entering the tissue. They perform their function and then die, becoming a major component of the pus that can form in certain types of inflammation. But their job is that of a frontline assault force, not a long-term cleanup crew. Following the initial wave of neutrophils, a second type of white blood cell begins to arrive on the scene. These are the macrophages. Macrophages are derived from monocytes, which are circulating in the blood. They are larger, longer-lived, more powerful phagocytes than neutrophils. They typically begin to arrive later, becoming the predominant cell type at the site of inflammation after about 24 to 48 hours. Macrophages continue the critical task of phagocytosis, acting as the cleanup crew. They ingest dead neutrophils, cellular debris, any remaining pathogens. Their work is essential for tidying up the battlefield so that the process of tissue repair can begin in earnest. Macrophages, however, have a much broader role than just cleanup. Unlike neutrophils, they are also key players in initiating the next phase, healing. They release a wide variety of powerful chemical mediators, including growth factors that stimulate the proliferation of endothelial cells to form new blood vessels, stimulate fibroblasts to lay down new connective tissue. As fluid and proteins leak from the blood vessels during acute inflammation, they form a substance known as exudate. The character of this exudate can vary depending on the cause and severity of the inflammation, providing clinicians with clues about the underlying process. There are several principal types of exudate. Serous exudate is the mildest form. It is thin, clear, and watery, composed mostly of plasma fluid with a low protein content. A common example is the fluid that fills a blister after a mild burn. It indicates a less severe injury where the vascular permeability is only slightly increased, allowing fluid but not large proteins to escape. When the vascular leakage is more severe, larger molecules like fibrinogen can escape from the blood. Outside the vessel, fibrinogen is converted into fibrin, a sticky, mesh-like protein that is the basis of a blood clot. This leads to the formation of a fibrinous exudate, which is thick and clotted. This type of exudate is often seen in pericarditis, or pleuritis in the lungs. The fibrin mesh can provide a framework for infiltrating inflammatory cells, but if it is not properly removed, it can lead to the formation of scar tissue and adhesions. A third type of exudate is purulent exudate, more commonly known as pus. It is a thick, viscous fluid that is typically yellowish or greenish and may have an unpleasant odor. Purulent exudate is composed of large numbers of living and dead neutrophils, liquefied dead tissue cells, and often bacteria. The presence of pus is a strong indicator of a bacterial infection, as bacteria are powerful chemoattractants for neutrophils. An abscess is a localized collection of purulent exudate. Finally, if the injury ruptures many small blood vessels, red blood cells will leak into the tissue, creating a sanguineous exudate. In other words, a bloody exudate. Sometimes the acute inflammatory response fails to eliminate the injurious agent. When this happens, the inflammation can persist for weeks, months, or even years, transitioning into chronic inflammation. This is a prolonged process in which active inflammation, tissue destruction, and attempts at repair are all occurring simultaneously. Macrophages and lymphocytes rather than neutrophils are the dominant cell types. This persistent inflammation can lead to significant changes in the tissue. In other cases, a specific type of chronic inflammation called a granuloma may form, where immune cells wall off a foreign substance, like the bacteria in tuberculosis, that the body cannot eliminate. Here are some short practice questions to help you study. They are written in a simple, direct style to test your understanding of the core concepts of inflammation. Read each question carefully and select the best answer based on what you have learned. The correct answers and brief explanations are provided below to help reinforce the material. 1. A patient presents with a red, warm, and swollen ankle after a fall. The swelling is primarily caused by A. Decreased capillary permeability. B. Vasoconstriction of arterioles. C. Increased capillary permeability. D. Decreased blood flow to the area. Answer. C. Chemical mediators make capillary walls more leaky. Protein-rich fluid moves into tissue, causing swelling. 2. Which white blood cell is known as the first responder and is the first to arrive at the site of acute inflammation? A. Monocyte. B. Lymphocyte. C. Basophil. D. Neutrophil. Answer. D. 3. A wound is draining a thick yellowish fluid that has a foul odor. The nurse would document this drainage as A. Serous exudate. B. Fibrinous exudate. C. Purulent exudate. D. Sanguineous exudate. Answer. C. Purulent exudate, or pus, is dead neutrophils, debris, and bacteria. Its presence strongly suggests a bacterial infection. 4. A patient has a high fever and an elevated white blood cell count on a lab report. These are examples of what kind of inflammatory signs? A. Local signs at the site of injury. B. Systemic signs of inflammation. C. Chronic inflammatory signs only. D. Vascular phase signs only. Answer: B. Fever and leukocytosis are systemic effects that affect the whole body. 5. The main purpose of the initial vascular phase of acute inflammation is to A. Permanently stop all blood flow to the injured area. B. Increase blood flow and allow cells and proteins to leave the vessels. C. Lower the temperature of the inflamed tissue. D. Create new red blood cells to replace lost ones. Answer: B. Vasodilation and increased permeability deliver immune components from blood to tissue. Clinical tip: remember the two main phases of acute inflammation. Vascular phase first, vasodilation and permeability. Then the cellular phase, leukocyte arrival and action. This video is created by a nursing student for nursing students. Please subscribe to our NS Study Room for more videos like this one. Go ace that test.